I don't want to spend a lot of time talking about me because I'd much rather spend a lot more time talking about our fantastic panelists here. And I'm going to call on each one of them to introduce themselves as well as give folks an understanding of the kind of work that they do. So let's start with you, Bo.
Sure, thank you. My name is Bo Wang. I'm an assistant professor jointly of computer science and LMP departments at University of Toronto. I also hold a CIFA AI chair at Vector Institute. My research has been focusing on developing novel machine learning algorithms to solve problems in biology and healthcare. I obtained my PhD from the Department of Computer Science at Stanford University, and my PhD work covered statistical methods for solving problems in computational biology with emphasis on single-cell analysis. And my long-term research goal aims to develop integrative and interpretable machine learning algorithms that can help clinicians with predictive models and decision support to tailor patient care to their unique influent genomic traits. And I look forward very much to the fruitful discussion with the panelists and audience tonight. Thank you.
Thanks, Bo. Mohammed, I'd like to call on you to talk a bit about yourself.
Great. Hi, everyone. It's a pleasure to be here. My name is Mohammed Mamdani. I'm Vice President of Data Science and Advanced Analytics at Unity Health Toronto, which is St. Michael's Hospital, St. Joseph's Hospital, and Providence Healthcare in Toronto. And I have a bit of a weird background. I'm a pharmacist by training. Did my PharmD at the University of Michigan in Ann Arbor, and then went on to do a fellowship in pharmacoeconomics and outcomes research, but also have an MA in econometric theory of all things. So 2 years of writing mathematical proofs that I'll never get back. But then I went over to Harvard to do an MPH in statistics and epidemiology. And at that point, I was so broke, I had to get a job. So I was recruited to Toronto and worked with a lot of big data sets, looking mainly in the areas of drug therapy and outcomes. And my current job right now is really at the interface between how we actually bridge advanced analytics solutions, including machine learning and AI type of solutions, into clinical care. And that's really been where I've been focused, is how do we actually glean the benefits of AI and machine learning from a clinical standpoint.
Thanks, Mohammed. Laura, I'd like to call upon you.
Good evening, everybody. My name is Laura Rosella. I'm an associate professor in the Division of Epidemiology at the Dalalana School of Public Health, also cross-appointed with LMP. I hold a Canada Research Chair in Population Health Analytics and Research Chair at Trillium Health Partners in the Institute for Better Health. And my research is really focused on creating data-driven tools, specifically combining multiple sources of data to develop and validate prediction models that can inform decision-making, both in the public health and health system context. I'm particularly interested in combining health and non-health data and helping us understand how that improves fairness and equity aspects of machine learning algorithms. And I'll say that in my most recent role, I've been really excited about how we build capacity in this space. I know that there's lots of people passionate about using data and analytics, and I'm really excited about creating new pathways to build capacity in this area, and in particular around education. So great to see you all.
Thanks, everyone. So it sounds like we have a panel with varied expertise, and that spans the breadth from algorithm development to deployment to thinking deeply about education. And that's great, because I think some of the audience questions that we've got in the past touch upon each of these different aspects. So what I'd like to start with really is a very simple question, and I'm going to throw it out to all of the panelists, and anyone should feel free to chime up, which is, why should we, and when I say we, I mean folks more generally in and around the LMP community, be excited about the potentials and promise of AI? And you can speak from your own perspectives on this, but what aspects about working in this space are you most excited about?
Does anyone want to start, or should I? I can give it a go if you like. What I'm really excited about is we see a lot of potential for AI to solve many, many different complex problems. Machine learning methods, I have to say, not machine learning methods can also solve all problems, and we have to be a bit careful in terms of what we pick. But I've been fortunate to be in a position to be able to see how we can actually bridge the gap between what we need clinically and what we can do computationally. And so what I mean by that is I have a team of data scientists that work directly with clinicians and administrators at the hospital. And first and foremost, what we do is we step back and try to understand the problem. What sort of a problem are we trying to solve? Do we have the data to solve it? What sort of computation methods do we need? And then how do we actually deploy it into practice? So again, what I get excited about is actually seeing the benefits of AI. And just to give you a couple of examples, if you're at St. Michael's Hospital and you're in our internal medicine units, you will be monitored by AI. So it's not an option. This is how we do care. So we have an algorithm that every hour for all of our internal medicine patients ingests data on over 100 variables, labs, medications, orders, vitals. And every hour it predicts at least 24 hours in advance if a patient is going to die or go to the ICU. And we've compared it to over 3,000 clinician predictions, and we know it does at least 20% better. And what it does is it gives our clinicians a heads up to say, we may want to pay attention to this patient, so could you go see them in the next couple of hours? And they can actually implement care pathways that are appropriate for that patient well in advance of what they normally would be able to do. And we're already seeing tangible benefits around how we've been able to identify things that we normally wouldn't have identified, and actually save lives in the process. So I'm super excited about how we can take the brilliance of data science and apply it to clinical care.
Thanks, Mohammed. Laura and Bo.
Sure. So I'll chime in here that I think the excitement around machine learning has really drawn our attention back to how important data is. And so while the methods are so exciting and they're allowing us to finally crack some of the challenges with the complexity and all the things that we have to consider when we make decisions, it's also making us focus back on how do we actually collect this data systematically, improve the quality of it, make it usable. And for a long time, that wasn't a number one focus, I would say, in medicine. We were really focused on generating high quality evidence, which is critical. But the data that's being collected every day, all around us in every interaction, we weren't using to the best of its ability, I would say. We were using it, but we could be using it so much more. So this has now drawn attention back to how important data and data systems are. And that has huge benefits, not just specifically for AI and machine learning, but for QI and for thinking about how we monitor and measure success. So that's what I'm excited about, data.
Thank you.
Yeah,
Bo.
I can supplement. So Mohammed talk about clinical applications of AI. Laura talk about educational side or data collection side of AI. I want to kind of supplement them by talking about genomics side with AI applications. So we see a trend, a clear trend of the rise of AI in genomics, which is not unsurprising. Genomics, a big data field, requires computational approaches to interrogate the enormous volume of data generated by the recent sequencing technologies and marry it in a meaningful way to mine useful biologies from this big data of genomics. And traditional statistical learning can help, but with the sheer number of genomic data available at this day, AI is kind of the right tool to mine this massive data set and find useful signals within this large-scale data set. We can do two things using AI for genomics. One is we can streamline some key analytical problems in genomic analysis. And second, further, we can generate new insights, new biology phenomena, new biology hypotheses from large-scale data sets. These are some exciting aspects I'm very interested in.
Thank you. So it sounds like, at least across the different domains, there's various aspects about machine learning and AI to be excited about. Laura raised a really interesting point, which is on this notion of the importance of the data and bringing to light the need to ensure that we're collecting data correctly, that it represents the underlying data generating process as faithfully as possible, so that when we build models off of that data, they then give predictions that are calibrated to our expectations. This is, I just wanted to throw out a broad question that is motivated by that observation, which is that Canada has one of the largest single-payer healthcare systems that serves a very rich and diverse population. And so the question that I have really is, what can AI do for a single-payer health system, and what can a single-payer health system do for AI?
I can start again. I think there's a potential and then there's reality, right? I think having a single payer system is fantastic in one respect, in that for a lot of services, you go through a single payer, and so the transactions now, because they're digital, there's a single point of data capture. So in theory, a single payer means an incredible amount of data collected for a kind of captive audience that could then be leveraged for use. And I think there's an incredible amount of potential. So for example, in Ontario, we have data stores in the Ministry of Health, if we're talking specifically about health, but we also have stores at the Institute for Clinical Evaluative Sciences, and actually in a couple of other places as well. I guess the downside to this is that we're a single payer system, but we still have a lot of silos. So for example, each hospital acts on its own. And if you want deep level hospital data, you don't really get that at a single repository. So you get broad, kind of big but dumb data, I guess you could say. It's still very powerful. And you just have to kind of shift which questions you're going to be able to address. The other thing is around timeliness. If you truly want at the point of care change, when you have delays of 6 to 12 months sometimes of getting data in at population levels, you're not going to be able to do that much with it in terms of real-time care. So I think it's a blessing and a curse in the same respect, in that we're not where we should be as a single payer system. We're still pretty good. We just have to be a bit smart about understanding what data we have. To Laura's point, it's all about the data, what we can do with the data, and perhaps a lot of times more importantly, what we shouldn't or can't do with the data.
Yeah, so I'll add on. I mean, I think a lot about bias. And one of the biggest challenges with a lot of the machine learning and AI algorithms is that they're trained on data. And that data didn't just get there. There's all these selection pressures that resulted in that population being selected. And as a result, the algorithms learn from those people and they represent however those people ended up in those databases. Now, with a single payer system, potentially some of those biases can be reduced. If we have one system and we're capturing everyone, we're not capturing who was selected one way or another. There are still biases there, but the idea of getting data on the entire population really is attractive in terms of what we can learn from a diverse, rich population where everybody's covered. And so that's what's exciting about it. The challenge is, in addition to what Mohammed mentioned, I'll say, is that we're really just capturing the transactions that are happening in the healthcare system. And actually, a lot of rich data and information happens outside or in hospitals or in other clinical databases that aren't always linked in. So the ability to link in these databases, again, both health and non-health data together, is really what is going to make the potential even greater. And so we have huge potential because we have reduced selection biases under single payer, but we have to be able to link across databases and concepts and domains to be able to really learn and create algorithms that are going to be game changers.
Thank you.
I want to add on from computational aspect. As we all know, to train a good AI system, you need lots of data because AI is very much data hungry. And many people are referring data as the new oil in the era of AI. And in this aspect, Canada as a single payer system is really advantageous because it can theoretically collect all the data. Although we know there are many practical challenges associated with it. However, it has lots of beneficials because AI is known to be less generalizable than many other traditional statistical learning methods. If, for example, if you train AI on one hospital, data from one hospital, they may not generalize well on data from other hospitals. So by aggregating all the data from different hospitals, from different systems, and it will benefit the training of AI algorithms.
Thank you, everyone, for those great insights. And I want to segue a little bit and touch upon a point that highlights some of the audience questions that we've received, which is around this notion of really joint decision making between humans and AI. And in all three of your descriptions of some of the areas that you're excited about, you touched upon this. Mohammed, in the context of warning clinicians when to have a second look at patients. Laura, in this notion of how do we make public health decisions? Because ultimately the policymakers are humans who are going to have to interpret this data and understand what the model is saying. And Bo, in the context of risk stratification for genetics, at the end of the day, these are going to be administered by clinicians. Even if the underlying models are the ones making the push, making these kinds of predictions. So I want to throw out a few questions, and we'll start with this one that was provided by an audience member. How do you foresee changes in AI affecting shared decision making in healthcare settings? Are there aspects of this collaborative nature of working with a human and AI that we ought to be taking into the design process, taking into account into the design process of the AI? How do we think about that? And in your own work or in work that you've seen, how have you seen this been tackled, if at all?
Yeah, I'll provide some thoughts. I kind of see three main areas, and arguably there's many more in terms of how AI can help clinicians and what that means in terms of automation versus assisting. So I think we can have algorithms to optimize what we do. We can have things to automate what we do, and we can have things that'll assist us in what we do. So in some cases, I think AI should be replacing humans, quite frankly. And I'll be bold to say that, because there are things we hate doing and we probably shouldn't be doing because they're a big waste of our time.
All right, give us some examples. I don't think you can make a bold claim without backing that up.
Sure. Yeah, now I'm going to forget what I said. So I'll give you an example of, all right, so our nurses came to us and from the emergency department, and they said, we hate assigning nurses to the different zones in the emergency department. It is awful, and it's one of our biggest stressors. And of course, from a data scientist perspective who doesn't live and breathe it every day, we said, are you kidding me? Like, what's the big deal? You just have to assign nurses. And they said, no. See, here's how it works. We have rules. A senior nurse must be paired with the junior nurse. There has to be a team lead in a given zone. And if this nurse worked in this zone, they can't work in the same zone in the past. And there's all these rules that come about. And so they literally spend 4 hours each day just on assigning nurse assignments to the different zones in the emergency department. And then they get complaints because the nurse says, well, I'm not paired with my friend, so you're playing favorites. And what ends up happening is what you want to minimize is the repeat rate. The repeat rate should be 0, but it ends up being 20-25%, which is huge. And that causes a lot of arguments. So it's a huge stressor for people. Now, as a team lead, as a nurse, you're going to spend, this is part of your job. You have to make the assignments. So we created an optimization tool where it actually follows which nurse, what skill level, worked with who, when, and follows all sorts of rules. And with a click of a button, it actually assigns nurses to the different zones. So they go from spending over 4 hours each day to under 15 minutes. The repeat rate goes from over 20% to about 5%. We've just taken a lot of their work away, and they're thankful for it because they can spend time doing more productive things. Yeah.
That's a great example. I think, if we were to build on that, you might also think about how one can add in nurse preferences. Like if they want to be paired with their friends, how can the optimization algorithm be modified to incorporate that kind of feedback? Yeah, I want to open it up also to Laura and Bo, just in the context of joint human and AI decision making, and your thoughts on it.
Yeah, I find this question really interesting because when we talk about AI assisted decision making, there's a lot of pushback, but we don't think about how we make decisions right now and how there's a lot of or a lack of transparency in how decisions actually are made without AI. And so I actually think it's opening up a can of worms, if you will, about how do we make decisions? What information do we need to justify those decisions? What's going into them? And when you look at it from that perspective, we actually find that we have a long way to go in terms of how we justify how we make decisions, period. And it's not necessarily an AI problem. It's actually transparency and trust issues. So I find it fascinating. Machine learning algorithms get interrogated so much regarding explainability. But if you show just a slightly different but statistical model, nobody can explain those you typically either. And so I think we need to rethink what we're actually worried about. I think it's a valid concern in this space because decision making should be transparent. We should be clear about what's going into those decisions and how we're guiding those decisions. And this is where I think if we use machine learning guided or assisted decision making, we can be clear. We can say, this is what the model gave us. This is the risk stratification. And this is why I'm deciding it this way or that way. And prior to machine learning AI, it would have been basically the same thing. It's just you're using less data, less points, and probably less accurate information to do that risk stratification to begin with. And so I think the other piece that really is needed is that we need to try to focus less on trying to understand the mechanics. Like, I think that's what everyone naturally wants to do. Like, tell me about everything about the performance and how it works and what's in the algorithm, which is, I think, really important as part of the validation for another technical user. But as users and in medicine and in health applications, we actually need to know it made a difference, a positive difference. We need to evaluate when you did an AI decision and maybe compared to a random group where you didn't, did actually patient outcomes improve? Was there less time used in the decision? Was it more efficient? All the different outcomes that you'd want to evaluate. And once we have that evidence, people will trust the process versus worrying about interrogating the specific algorithms. And then I think we'll be able to make significant advances.
But can I just comment on one other thing real quick to the clinicians?
Yeah, go for it.
I'm going to call on you folks. So you know how we make decisions on the floors, right? I mean, randomized trials, sure, but most randomized trials exclude 80 to 90% of the patients that you'll see in clinical practice. So at the end of the day, how many of you raised your hand and said, it's clinical intuition, that's how I'm making my decision? We do that all the time. So how is this going to be any different, really? To Laura's point, absolutely, yes, we do need to understand the mechanics, but honestly, the performance is going to be what makes a difference.
Thanks. Bo, I was curious, at least in the context of genomics, where, maybe explainability may not be something that is in reach because just because of the sheer magnitude of the number of features that are often required to build some of these risk stratification models. So I was curious about how you think about this problem in the context of geneticists and clinicians working with risk stratification models.
Yeah, that's a very good question. Right now, AI for genomics still most of the time focus on research side. And AI has been widely used as more like augmenting tools for clinicians and biologists to help them understand better about their data set. If I summarize the utility of AI in decision-making for genomic side, I want to say AI, two aspects of utilities for AI. First, AI has been greatly used to help streamline some mundane tasks for genomic analysis. Just giving you an example, when we collect single cell data, most of one sample contains tens of thousands of cells. And what usually people do for biologists is they're going to, call a graduate student and ask them to spend hours or days of work to classify each cells to say this is T cell, this is B cell, by looking at certain marker genes. Apparently, this is a very mundane task, and many graduate students are trained to do so. And so right now with AI, it takes seconds to finish all the annotations automatically. So this is an example how AI can streamline some key analytical problems in genomic analysis. Second part is more active. AI can be used to generate some new insights or new hypotheses from the genomic data set. Because to be honest, biology still is an unknown field to many people. And we want to generate some new hypotheses to understand better about the disease, to understand better about the genomics data sets. And AI is really to be used to improve our understanding of genomic variations in relation to health and disease, because there are so many data sets, human just by eyeballing just impossible to find some novel signals.
Thank you. Yeah, I think the role of some of these techniques in hypothesis generation, even from a clinical perspective, is interesting when thinking about can you identify subgroups of a disease from the clinical variables that you do observe. So I think the phenomena that you mentioned in the context of genetics also has a role to bear in other parts of healthcare data. So, we talked about some of the workflows that all of you envision in seeing how machine learning algorithms and humans can cooperate, or in some cases, just take the workload away from the humans that they didn't want to do anyways. Are there potential side effects that we foresee? And, this is a really interesting question because the adoption of every new technology comes with some inherent risks, many of which are not actually observable at the time the technology is deployed. And a really prime example of that is when we think about the rise of social media and some of the ramifications that it's had both in society in terms of mental health. And so I want to bring this question up because I think it's important as to think about what are potential side effects that you may see, and how can we be more vigilant in terms of thinking about ways to mitigate them as they arise.
Yeah, maybe I'll start again. I think there are several examples of this which kind of illustrate all the kind of challenges to understanding workflows and end users. Maybe I'll just point out one. There's a really neat experiment in Europe where there's a group who developed an algorithm, risk prediction algorithm, which basically addressed the issue of febrile urinary tract infections. So the concept here is somebody comes to the emergency department with a fever, low back pain, and you suspect infection in the kidneys. And your options are, I'm going to admit them, or I'm going to send them home on antibiotics. And a lot of times we don't know what to do. So they created a risk prediction tool and they randomized over 30 groups. One group to use the tool and the other group to not use the tool. And what they found was that the group that used the tool had a lower rate of admission to the hospital, but they had to stop the trial early because when they followed people up, they found that the number of people coming back to the hospital with complications increased fourfold in the group that was using the tool. And that was a sign of harm. So they actually said, oh, we got to stop the trial. And you kind of wonder what happened. If you follow the process, when the scientists created the algorithm, they looked at their data set and they said, we'd love to look at mortality. And then they dug deeper and they said, we don't have enough data and the quality is not there to look at mortality. So I don't know, let's pick something else. So they have to shift what they were doing. They were smart enough to do that. But then when they developed their algorithm, they said, it's a lot of work. There's an algorithm that looks at pneumonia, and that's a disease of the lung. Why don't we just take that and strip out the lab values? Okay, maybe that wasn't a great idea, but that's what was done. And then, of course, they said, well, let's deploy it. We didn't quite educate the clinicians on it. So many of the clinicians said, what the heck is this? And in over a third of low-risk cases, the clinicians overrode it because they didn't understand the prediction tool. So there are all sorts of points of failure of understanding how you develop an algorithm, the clinical nuances, and what clinicians expect to see in the workplace to actually be able to use the information in a positive way. That could be points of failure here, and then result in unintended consequences.
Yeah, that's a really interesting anecdote. I think one of the anecdotes that well, one of the concerns that I think about a bit is in this notion of confirmation bias, which is you have an algorithm providing you a prediction. If you see that prediction, do you like sidestep the clinical decision-making process that you otherwise would have followed for this patient? And so this notion that the algorithm gives you confirmation on a guess that you might have means that you don't actually do perhaps a follow-up test to reconsider whether that's the right decision is definitely a concern that I think about. Laura and Bo.
Yeah, so I'll tell you, two things keep me up at night. The first obviously has to do with bias. So all the algorithms that we create learn the inherent biases in our data, and they learn them, they deal with the measurement error. And because it's not common practice, although I hope this is something we change, to measure bias, to quantify it, and to test for it all the time, it can go unknown until you implement it, and it could propagate. And because of the scale of machine learning algorithms, it could make a bias that's small or operating at small scale, large scale. So all of a sudden we're applying this to populations, millions of people, and it creates huge issues. So that, I think the biases that can exist and how easy it is to learn those biases, integrate and propagate is a huge issue, which needs a lot of attention. The second issue is a little bit different, and that is maybe an issue of success. So if we have an algorithm that's so successful and does really well, but it only works for a small group of the population. And so, and maybe even not necessarily a small group of the population, but for a very specific condition, we can actually start to widen health inequities. And this is also an inherent risk with any new technology, any new medicine that isn't available to the entire population. You can actually worsen the population health by widening health inequities. And I think both those are possible and real risks when it comes to development and validation of these algorithms and the implementation of them.
Thank you. I think that's a great point to highlight, specifically since there's, there's a very obvious desire to say that, well, this works for this subset of the population. Let's see what we do in practice. And as you rightly point out, doing that repeatedly over decades and decades leads to other subset of the population missing out on potentially better care. Bo.
I think when it comes to genomic analysis, some of the concerns are shared. For example, bias, because some of the AI can only learn from what it is fed, right? So in most of the public genomic data sets, most of genomic data sets coming from US and England, these are countries where provide lots of genomic data for people to do research on. And therefore, many of the risk scores developed from these data sets are not reflecting the true risks from some other minority groups in which the data has none about. Therefore, some of the risk models developed from these data sets may be biased. And if you use these AI models without further investigation, it may cause problems. Another risk, particularly to genomic, is privacy concerns, right? With the growing scale of patient data, particularly genomic data, how to preserve the genomic privacy is a key issue. It's still an open research problem. There's no good solution to it right now. And although there are certain ways to alleviate the risk, but so far there's no legal regulations, there's no technical guarantees to preserve the privacy. So if I summarize, bias and privacy concerns are the biggest challenges when it comes to genomic analysis.
Thank you. I think that was a great set of responses that already begin to partially address another one of our members' questions that was sent in, which was about bias in training data and how that affects downstream application of the resulting AI models. I think this is a good point for us to make another segue into thinking a little bit more broadly about perhaps some of the dissatisfactions that you have with the current state of both research as well as the application of AI in healthcare. And we've talked, in the first part of this fireside panel, we've talked quite a bit about some of the excitement. And so I want to make sure that people see the other side of the coin. So I'm going to call on you just to talk a bit about, at least within the context of your research, what are you unhappy about, and what do you think that the community can do better?
Sure. So I'm pretty excited about the space, but this is probably a biased panel. But I think if I had to pick on a few things, I would say one is it's about the data, to Laura's point, as she raised early on. I think for as you had mentioned, Rahul, a single-payer healthcare system that has pseudo universal healthcare, you think we'd be in a lot better shape in terms of consolidating our data and being in a position to really leverage it in its maximal capacity. And I just don't think we're there yet. I think it's forcing a lot of us to be a bit more thoughtful in terms of which questions we pick because of all the nuances in terms of data limitations in quantity and quality. If I had to pick one other area, I would say it's, I think we're actually doing reasonably well, so I shouldn't be too critical about it, but it's culture. We're getting there, but I think there has to be a culture to really embrace this sort of these sort of technologies and approaches, because I don't think it's a matter of choice. It's coming whether we like it or not. We've seen the taxi industry upended by Uber. We've seen retail upended by Amazon. We've seen all sorts of transitions in other sectors. It's happening in healthcare, whether people like it or not. And I think the culture needs to catch up to the times.
So when you say the culture needs to catch up to times, you mean both in the context of data sharing as well as the adoption and experimentation with some of these AI tools?
Yeah, and also embracing technologies, right? I mean, it's incredible how prevalent faxes are in healthcare. And we've all talked about it. Why are we still faxing? But I think we need to get over this mindset of let's stick to what we know. And I realize we're conservative and we don't like high risk because of the nature of the work that we do.
Yeah.
But I think we have to be a bit more open.
Thank you. Laura and Bo?
Yeah, so I'll say a couple of things. So one is on the culture piece. I think there are amazing demonstrations of collaborative groups. This is multidisciplinary. In order for it to work, there has to be a problem it's applied to and lots of perspectives on the issue. And I think everyone on this panel participates in those collaborations. So I don't want to make it sound too bad, but I do think there's a lot more focus on our differences rather than our similarities. And so especially, I think it's been getting a lot better, but a lot of tensions between, well, why is that different than what we did before? And, I call it this and you call it that. And I think that held us back quite a bit, especially in the early stages. I'm seeing a lot of those barriers break down. And I also think the role of the connectors, the people that actually can sit in multiple worlds are really helping these multidisciplinary collaborations move forward. So that I'd love to see more, focus on the similarities and the goals of what we're trying to achieve versus the differences. The second thing I'd say is the type 3 error problem. That's the right solution to the wrong question. I think there's just amazing, tremendous advancement in this space, but I'm not sure we've been answering the most impactful questions. And so I'd love some of the energy in the space, and that, of course, I'm a bit biased to be tackling, big public health societal issues, or really impactful clinical operational issues, which would affect a lot of people and make a huge difference. And so, the idea of getting the questions, and Mohammed talked about this in the beginning, getting the questions and making sure we're aiming this amazing talent at the right questions, I think we could be doing a bit better.
That's a really interesting point in terms of, the right solution to the wrong problem. I just wanted to poke at that a little bit more. That at least in the context of some of the interdisciplinary work that I've seen, there's this notion that a problem is inherently more interesting if the solution required is a little more complex, which as you rightly point out, is just patently false. And like the simple solutions often, perhaps even using existing tools, often go a long way to making meaningful change. How do you think we can break some of that inherent complexity bias that exists both within the technical groups that work on problems in healthcare, as well as the clinicians interested in saying, hey, these are the high impact problems, please work on them. And yeah. I'm going to make the data, shared, openly available, and I just want to see this solved.
Yeah, so this is academia fuels this problem, right? So because we in academia, you don't typically get rewarded for doing something, that was done before. You get rewarded for coming up with a new solution. When in fact, some of the, I work a lot with decision makers, and most of the time I'm using tools which are not new to academia. So it's hard to get academic credit for solving that problem. In a business situation, that wouldn't be the case. You would have the problem presented to you and you'd say, what's the best way to solve this problem? Whether it's new or old, that's sort of secondary. And because our incentives in academia are to constantly produce the new, I think it pushes us to always think that way. So I think we have to work on some of the incentives for really smart people that work in academic spaces that want to work on impactful problems, making sure that they're recognized for that work as well, and not just the academic novelty or the scholarly novelty of the work. So I think the academic culture in some ways causes us to have this type 3 error all the time, because we're just focusing on the tool, making the tool better, and not thinking about the context in which it needs to be applied.
Thank you. Bo, I'd love to hear what you'd like to add to that.
Yeah, I can talk about 2 cents as a data scientist. I've been collaborating with lots of clinicians for quite a few times. And if I really want to summarize some dissatisfaction for this field, I want to mention 3 points. One is lack of sufficient data access. Myself as an example, to gain access to data from different hospitals, I have to be affiliated at different hospitals. So what end up is I have almost 10 badges to different hospitals. So you can see the difficulty to gain access across different hospitals. And we are really not taking the full advantage of the single payer system, as we mentioned before. This is the biggest headache for me as a data scientist. A second point I want to mention is lack of real world adoptions. So many researchers, they collect a bunch of data and then they develop some method and then publish and then they walk away. So this is so-called AI chasing, in which we want to, to chase the numbers. We want to chase the best AUC numbers, and without considering how to adopt these complex, bulky models into real-world clinic settings. And the last point I want to mention is the lack of real collaborations or trust or communications between clinicians and AI scientists. So what happened most is a scientist, a clinician who are interested in working some new ideas and find me and saying, here's the data, go nuts and pull the rabbit out of the hat. And what really make a successful AI project in healthcare really needs lots of back and forth, right? AI is no magic. You cannot just pull the rabbit if you don't even have the hat. So many times we really need inputs. We really need some prior knowledges from the clinician saying, hey, the AI finds this one, can you verify this make any clinical sense? If not, we can go back and do some debugging. If yes, this is very encouraging, we can do further, and we can dig deeper and find some novel insights. So because we speak different languages, what happens mostly is, we think clinicians are talking about something crazy, and vice versa, same hold. They think we are some magicians, we just pull the rabbit out of the hat directly without even think about what's required by AI, right? You need a careful data cleaning, you need a careful harmonization of different variables, but many people just don't think of that. So there's really lack of communications, lack of collaborations between clinicians and data scientists.
Thank you all. Those were incredibly insightful answers, I think, to this notion of how can we think about what is a more sobering take on AI in healthcare, and what are the pain points that we really need to improve. To Bo's point about this problem of, if you're trying to hit a baseball, you should complete your swing. You shouldn't stop halfway. I think there's a paper called Machine Learning That Matters by Kerry Wagstaff, who is a researcher at JPL, that highlights exactly this. And I think across all of the subdisciplines that our panelists work on, I think it's incredibly important to think through how we can both encourage in academia meaningful incentives that allow for researchers to work through and see their problem to the finish line. Great. I want to, we're nearing the end of the fireside session, and I'm going to segue into our last and possibly final topic for the night, which is this notion of policy. At least in the context of the last 3 decades, what we've seen in a variety of different examples, be it social media, be it streaming services, is a mismatch between how policymakers who regulate the way that companies should behave in the context of certain technologies and the actual reality of how these technologies are deployed. And so it wasn't until some of the depositions, more recently in the context of Mark Zuckerberg being called to Congress to investigate the role that Facebook had in a variety of different scenarios, was this idea that, hey, maybe we should be regulating social media technology a little bit more carefully, because there's a ton of unintended side effects that are posed by its existence and continued use by a population that perhaps isn't ready to, work with these tools. I want to probe and hear everyone's thoughts on how can we meaningfully engage as academics with either policymakers so that they're making the right kinds of decisions that both allow these tools to be developed and flourish, but at the same time, protect patient privacy, mitigate some of the biases that Laura mentioned, and in essence, and this points to one of the questions that we've received: what kind of recommendations would you give to ensure the safe and ethical use of AI in medicine?
Maybe I can take a stab. My sense is, at least my interactions with policymakers and regulators has been actually reasonably positive in that they listen and they want to engage, because I think the reality is that they're trying to figure it out themselves, and they need help. And I think they actually do embrace feedback and guidance on this. I guess the expectation should be, though, from academics and researcher types who want to engage in these dialogues, don't get frustrated, because it is a very complex area. And if you have the notion to come in to say, this is how it should be, and so I expect you to do this in 6 months, it likely won't happen. There are so many factors at play that often what happens with policymakers, and Laura has considerable experience working with decision makers, is that you end up not quite where you thought you would be, but you're trying to actually make many, many different audiences happy or not incredibly upset. Maybe that's the best way to put it. So how do you balance the lobby groups and the for-profit sector or the private sector and the academics and patients? It's a tough act. So yeah, I would say, actually, I think they look for advice, and I would say I would encourage researchers to engage with policymakers, but I would also expect understanding and patience.
Yeah, and I would
Thank you.
add that we're really early on in this, right? And so adopting that learning mindset right now is really critical. The idea that we're going to dip our toe in, and we've started some of the implementation, and there's going to be rapid learning and changing that needs to happen. Just accepting that right off the bat will help avoid some of the frustration Mohammed was talking about. We need to find our way here, and it means that you know, it's impossible to expect it to go smoothly and to end up where we think we are. And we also need to allow for that evaluation to occur. This time period now where we're embarking and starting to implement is the most critical time to evaluate and learn. And you know, if we're all honest with ourselves, that's best done by someone that's not involved. So there does have to be some third-party oversight and evaluation and recommendations. And it shouldn't be the people that are implementing and developing. It should be someone else. I mean, that's the model we use across lots of aspects of medicine, as well as policy regulation. And so I think there is a role for some third-party oversight, evaluation, governance. It doesn't have to be painful, especially if we adopt a learning mindset as we embark on this journey. We'll save ourselves a lot of headaches down the road. We don't want to be 10 years into this with tragic results, and that will just set us back all the way and result in a lot more restriction. If we sort of just embrace this and these initial steps as we know we're going to have to go back and revisit things, how can we do better? And we form those relationships, and we allow, you know, oversight and governance in a responsible way, then I think we'll be a lot better off.
Thank you. Bo.
Yeah. First of all, I'm no expert in this field. I'm not an expert in policy and ethics of AI. However, through my very limited interaction with policymakers, I find the experience very positive. They were very eager to learn. They will call me or email me saying, hey, I have this application. I want to know more about the technical side. And by actually communicating with them, trying to explain them about the technical side of things, we actually find some common ground, right? For example, I will explain how the overfitting is going to occur at different settings, and then they will ask, hey, how do you make sure you understand your model? And I would say, we actually don't. And he will say, hey, you guys need to work on this. And this kind of is actually a research area we are actively working on. So I found the experience very encouraging and very positive. I guess one of the best advice I learned from my colleagues and many collaborators is being humble. This applies to both sides, right? You have to understand the pros and cons at technical side and also policy side.
Thank you. I think that those, you know, touched upon some of the interesting areas and thinking about how we as academics can meaningfully engage with policymakers as work and research in this area becomes more prevalent, and as some of these models are deployed. And you know, to the points that we touched upon earlier in the fireside, there's going to be these side effects. We just have to be prepared to know how to recognize them and immediately take action. And so and for that to be successful, we really do need to work with a broad interdisciplinary audience. So it was really wonderful to hear all the thoughts that each of you had on this topic. We have a final 6 minutes, and so as we're nearing the stage of the night where we you know, wind down and think about some of the reflections that we have, I wanted to give each of you a chance to talk for a few minutes on what you think some of the key takeaway points that the audience should have from both our discussion here. Some of them may have interesting questions in terms of working and applying these techniques. Would you have any advice for them? Really just, this is not me asking you any question, it's whatever you want to talk about.
Yeah, maybe I can start. I just want to say to the group, this is an incredibly exciting field. Normally, I kind of step back and say, what's going to stick and what's kind of fashion that will see another wave. I don't think this is fashion. I think this is here to stay. It's had radical changes in other sectors. It will inevitably in healthcare. We're just warming up. So I'm incredibly excited about this space. The one thing that I would say to everyone, I think Bo put it very well, and Laura as well, collaborate, collaborate, collaborate. This is a team sport. It is really hard to succeed here without collaborations. So I'd really encourage data scientists, so people in computer science and statistics and engineering, to work closely with clinicians, nurses, doctors, administrators at the hospital or clinics to really jointly develop really interesting solutions to interesting problems, both at the academic end, where you can have those cutting edge methods if you just have insights into the contextual domains, but also in an applied way where you can really make a difference to the health of everyone we serve.
Thank you. Laura,
Yeah, I
I'll
guess
call on you.
Sure. Some final. It's been a really great discussion, and I guess some final thoughts. I just want to I want to share how we're thinking about learners at TCARM, because I think that helps everyone realize that everyone has a role in this space. And so when we're thinking about building capacity, we sort of think of the applied clinical user. So these are clinicians and they're working in their clinical fields, but they're going to come across AI and it's going to be more ubiquitous over time. And so how can we focus on being comfortable with that? How do we build trust? How do we know it's good versus bad? These are some fundamental skills that I think any clinician should think about building as part of their clinical practice. And then there's the technical experts who are the methods innovators. And for these people like Bo, you know, I think you heard today, they want to hear what the problems are. They have the solutions, they have the innovation in the space, they have the passion to work and solve those problems, but they really it needs to be clear what the problem is, and then that continual engagement. And so there's people that are going to work on the innovative technical solutions, and also that continual engagement needs to happen. And then there's the application of AI. And this is what we've actually been talking a lot about that. It can go really well and it can go not well at all, and actually can cause a lot of harm. And so we actually need people to think critically through the application of AI in clinical settings, in medicine, for healthcare. And this is where, again, lots of people have a role to play in this space, and actually there's innovative scholarship. And so hopefully, you know, everyone can see a role for themselves in this space, you know, and engage and try and find, you know, the right tools and training to be able to engage in a way that they know will have impact. Because I truly believe the more people that are involved, the more, you know, aspects and point of view, we have the unique advantage of being able to tell, like, write the story right now. We're just warming up. We're right in the beginning. So let's create it in a way that's going to be useful for all of us. And that will happen if there's multiple perspectives involved.
Thank you. Bo?
I think Laura and Mohammed covered very well. I'm very excited about this field, and AI can be very potential and revolutionary for healthcare and biology. If we really want to say something, I want to say, let's pull the rabbit out of the hat, but we have to do it together.
All right. All right. I think we are almost. Oh yes, Mohammed.
I could just add one thing just to plug for TCARM, the Temerity Center for Artificial Intelligence Research and Education in Medicine. If you're part of U of T and you haven't joined, please do. I think it's a phenomenal group, and we're doing a lot of things that we talked about here. Is we're trying to build the community where people really play and work together. Thank you.
Thank you so much. I had a wonderful time learning from all of our fantastic panelists, and thank you all for a great discussion.